Hi, everyone. Good evening to those of you who are joining us from Asia, and good afternoon, good morning, depending on the part of the world that you're joining us from today. I'd like to welcome you all to the second in the series of webinars on data quality hosted by the National Data Quality Forum. My name is Nidhi Khurana, and I am a knowledge translation specialist with the Population Council. I'm a health systems researcher, and I work at the intersection of evidence and impact, essentially guiding investments in public health programs and furthering evidence-informed public policy. And I will be moderating the session today. The primary goal of our webinar series is to foster a community of practice by providing a platform for a meaningful dialogue on data quality between the producers and consumers of health and demographic data. The forum is focused on three thematic areas: nutrition, immunization, and family planning. So please look out for more webinar invites over the next 3 months, and we'll be looking at meeting you about twice a month. I'll also take this opportunity to make a brief plug for our upcoming panel discussion, and this will be on collecting high quality data using phone surveys, especially given the constraints imposed by COVID-19 on field-based activities, in-person activities. This is on May 21st at 6:30 p.m., and you should hear more about that early next week from us. With that, I will introduce today's session, and our point of interest today is assuring data quality for anthropometry. And there are certain unique considerations when we talk about nutrition data quality and collection of anthropometry data or anemia data requires quality measures which are markedly distinct from, say, interviewing. And providing reliable estimates of anthropometric data is important for monitoring progress towards eradicating hunger, reducing health inequalities, and assessing the impact of health and nutrition interventions. To help us navigate the special case of collecting high quality anthropometric data, we have Robert Johnston from UNICEF, who will discuss today how standardization methods and training impact the quality of anthropometric data, drawing on the experience of the Comprehensive National Nutrition Survey. Robert is a nutrition specialist at UNICEF and has 20 years of rich experience in public health nutrition. He has worked in Central America, he's worked in Southeast Asia, Sub-Saharan Africa, and of course, India. And his specific interests in the field of nutrition include data for decision making, anthropometry, biochemical assessments, and using technology for improved monitoring and evaluation. We also have today Professor Irvin Pandey, who is a well-known authority in the field. He is the National Chair in Medical Statistics at ICMR and a former director of the National Institute of Medical Statistics, which essentially hosts the National Data Quality Forum. Professor Pandey is also a member of India's National Task Force on Operations Research for COVID-19, and he has several honors and awards to his credit, and his areas of specialization include statistics, epidemiology, and population studies. I would like to do another quick check off before we get moving. So in line with the nutrition theme, the NDQF website has an infographic out this week, and it shows how the accuracy and precision of measuring hemoglobin and consequently anemia prevalence varies by method and place of blood draw in children. And I will really urge you to check it out, and you should have a link coming up in the chat box to that infographic. Finally, I would, before I start the session, before I turn it over to Robert, there are some house rules. All attendees are going to be on mute until after Robert finishes his presentation, and then Professor Pandey will make his comments. And finally, we'll open up to the audience for discussion, and we are going to take questions in batches of 3 to 4. You should see a hand icon right in front of your name. You can raise your hands virtually, and we can take your questions there. Alternatively, you can also type into the chat box, and that's the other way to ask the questions. Whilst asking, please identify yourself, make your questions pointed and brief, so that we can get through as many of them as we can. And with that, I'm going to turn it over to Robert. And here you go, Robert. You are the presenter now. Over to you.
Okay. Wonderful. Thank you. Thank you, Nidhi, for that introduction. And just want to say, I tried to share my screen. Is that working? I'm not sure if it is, but yes, you can see my screen?
Yes. Okay. I can.
Good. And here's the presentation. So yes, I just wanted to say at the beginning that yes, it's a pleasure to have a chance to present here to the National Data Quality Forum, and especially on this work around the Comprehensive National Nutrition Survey. It's a great honor to be a part of this Comprehensive National Nutrition Survey because it was the largest micronutrient survey ever conducted in the world. And so to have a chance to work on something like this was just a huge opportunity for me, and to work with the Population Council, with other institutions working on this study, and with the national and internationally renowned academics that were part of the technical advisory group. It's a fantastic experience. So now we're thinking about the context that we're in the era of the COVID pandemic. And in this context, all household surveys have been shut down, and there's no contact between interviewers and respondents, except by distance, non-invasive methods. And so we're required to adapt our tools and methods. And in this context, we cannot foresee how to collect data on anthropometry over the phone, but we know that we'll go back to a period just like we did in the Ebola crisis, where we do start to go back and collect data and actively monitor the effects of the epidemic on the population to make sure that we can help prevent food security and nutrition crises, or respond if they do see something rising, that we can respond to them quickly. So in this terrifying context of the pushing COVID epidemic, I want to make the point that these methods that we're going over today still have a very strong importance in our work, and that we will have the need to put these methods to use as soon as possible when the lockdown comes to an end and when we're able to go back to data collection at a household basis. So on the negative side, we're facing a lot of threats that we can't predict very well around food security and nutrition crisis. But on the positive side, we have an unparalleled opportunity in this crisis to focus on behavior change. And I'm thinking about behavior change specifically around hygiene, and the attention that we have, the focus that we have on hand washing, on stopping spitting, on latrine and toilet use, and proper hygiene around all of these aspects is unparalleled. So I think that the positive side of this lockdown and the attention given to the COVID pandemic gives us a huge opportunity to improve public health. And next slide. I'm not sure if anybody in the audience has been watching as much Netflix and Amazon Prime as I have, but in the beginning of the shows on Netflix, you always start with a car crash. And so that's why I started with this car crash here. Oops, I just made a mistake. Let me see if I can get the come back. Where's my screen? Come back. There we are. Okay, I was trying to hide this little, trying to hide the buttons, but there we go. I show this car crash because I have a metaphor to make, that you don't give the keys of the truck to the driver until they demonstrate they can drive. Now, this was a quote that was taken from the chief of nutrition of the Ministry of Health of Nigeria when we went through the standardization process for the first time. And he said, of course, you make sure that people can do their job before you allow them to go out and do their job. And you make sure that you train them and test them so you can deliver upon the data quality. And so the point is that it's dangerous to give keys to a driver if they don't know how to drive. And it's also dangerous to give height boards and scales to people when they don't know how to use them, right? So we have to make sure that they can use them before we send them out to do their jobs. Now, I just want to go over some essential resources here. You've got links to all of these in the presentation that we can share with you. The first one is How to Weigh and Measure Children from 1986, and all of the methods that I'm going over were included in this document. They've been updated since that time, but all of the hard work on methodology development was included in this document. And secondly, the SMART methodology document. This is from 2017, but this one came out in 2005, and it was the compilation of all best practices around doing nutrition surveys. It's a very important document. And then finally, the UNICEF WHO team document. This is a document that has started to recognize the issues that were brought up in the first document, How to Weigh and Measure Children, and the SMART Methods document. And they're recognizing the problems that exist in our global databases around nutrition, and they're trying to address them with guidance. So it only came out last year, but it's very well received, and there's still a lot more work to be done on how to cover the methodology for improved measurement of anthropometry. So I want to go over the points accuracy and precision and how we measure the type of error that we see in anthropometry. And I'm starting with precision. Precision is, you can see the red distribution around the mean. So precision is how close our measured values that are coming from our survey instruments, that are coming from our survey implementers, our interviewers, how close those measures are to each other, right? But accuracy is how close that measured value is to the actual true value. And the difference between the measure and the true value is a bias, right? And so this work that we're doing and the work that is included in those past documents covers about how to eliminate bias, and then for precision, how to reduce our uncertainty of the measure. So how do we eliminate bias? Bias can be eliminated once you recognize it and you address it. For example, when you measure a height with a broken height board, you're introducing bias. So you use a well-functioning, good condition height board. If you weigh height with shoes on, you're introducing a bias. You take off the shoes. If you measure weight with clothes on, you take off the clothes and you remove the bias. And this is one of my all-time least favorites. When you measure the weight with a scale where the cardboard protection is still in place and it prevents the feet from sitting on the ground. And I find that way too often when I'm doing the review in the field. Also, using the middle upper arm circumference when you're using too strong of a tension, or if you're measuring the wrong arm in the wrong position of the middle arm, that also introduce bias. Imprecision or uncertainty cannot be eliminated. It can be only reduced, right? Because the precision is dependent on the sample, of course, but also the survey instrument and also the anthropometrist, the person using the survey tools, right? So random error will cause a decrease in precision. And to decrease that random error, we use a very rigorous training and standardization and supervision. So why is this so important? Because here I want to show you a height for age distribution that is similar to the past one that I just showed, but with the introduction of random error, right? So the random error is causing greater uncertainty and less precision. So here in this distribution, the red distribution is the survey distribution that I've added random error from plus or minus 1 month of age and plus or 1 minus centimeter of height added. The green distribution is a normal distribution with a mean on 0 and a standard deviation of 1. So you can see the difference when there's random error introduced into the distribution, that there's a flattening of the curve with an extension of the tails of the distribution. So why does that make a difference? Why is this important, right? That's the important question. And does it happen in real life? So here's a survey from the country of Mali, demographic survey. And here you can see the actual height for age distribution in that survey. And so the random errors that look like they've affected the data here, they may or may not change the mean z-score, but they greatly affect the height of the distribution and the extension of the tails. So you see that the prevalence of stunting is based on the proportion of the population below the cutoff of -2 standard deviations. And so you can see on the left-hand side of this distribution, the overestimation of population that is found less than 2 standard deviations because of this random error, because of the flattening of the curve, because of the excess population that is found in that left tail. So the random error creates a gross overestimation of the population in the tails of the distribution. And you'll also see it's on the right-hand side of the tail. So in this population, we have an overestimation of stunted children and an overestimated estimation of children who are too tall for their age, right? So this is something to keep in mind when you're doing your studies. And here's a link to a paper that goes much more in depth on this issue, the effect of the random error on diagnostic accuracy with the anthropometric diagnosis of malnutrition. So now that we know that bias is important to eliminate and random error is important to reduce to the maximum, we go into how to manage these issues. So just coming back to the CNNS, the Comprehensive National Nutrition Survey, measured for the first time in India all children from 0 to 19 years of age. So the first time of this age group from 5 to 9 years of age, and the first time for male girls and boys from 10 to 14 years of age. And among these anthropometric and physical strength measures, we measured height, weight, middle upper arm circumference, and tricep skin fold, subscapular skin fold, waist circumference, and also hand grip strength. So since it was the first time to have all these measures together for this entire population of children and adolescents, it was important to get it right. It was important to do our best, our maximum, to ensure that these data would be received, well received, recognized to be data quality, and put to use. Just quickly, other data quality assurance measures that we used, besides all of the training and piloting of the field work, we also used data quality assurance team, looking at consistency checks, coordination, providing that feedback to teams, making sure that we didn't have interviewer fatigue causing bias with no more than 4 interviews a day by a data collector. And then for the biosample, we had cool boxes that you see on the top left, and we had data loggers that would track the time and temperature of those data, and also we had an SMS system that we could track the transport of the sample from the field to the collection point to the reference lab. And with these tools, we were able to maintain the cold stores of that sample in the cool box for up to 16 hours during the transport. The standardization procedures for anthropometry, on this page I'll go in a clockwise fashion. It starts with the standardization equipment. And so this is what we did before we even started to do the anthropometry training. We took all the equipment, we assembled it, we numbered each piece, and then we tested each piece. We tested the height with the height boards, the weights with a standard weight, the measuring tapes with a standard circumference, and the skin fold thickness with a standard thickness. and we tested each one to make sure that we got exactly a precise measure from that tool. And if we found that any tool was in poor condition or wasn't producing a precise measure, then we put it aside so it would not be used during the data collection effort. So all tools were found to be operational within their expected precisions before we went to the next step of the standardization of the anthropometrists and the assistants. And in that process, following the anthropometry training, we set up a room with 10 posts that are numbered with one child per post. And then that each post also has a caregiver that is protecting that child. So the 10 anthropometrists in the room are assigned to measure each of the children twice. That means they start and they make one round and they measure all 10 children, and they hand in the piece of paper where they've measured, where they recorded all those measures. They take a break, and then they do a second round where they go through the room again and the second pass and measure all the children for the second time. Right? From this, we're able to calculate the accuracy and precision of their work. And those who did not pass in the first round were retrained and retested, and only the anthropometrists who passed the standardization test were employed. And lastly, we conducted a standardization of our tools during fieldwork. At every cluster before the start of data collection, we would test all of our tools and revise the conditions of those tools to make sure that they were in good condition before we started the data collection in that cluster. So what were we able to achieve in the standardization tests and training? We were able to ensure that all of our employed anthropometrists were able to take measures here of height with the required accuracy and precision. So here, accuracy is represented by the intermeasurer technical error of measurement. And that means that the measurer was compared against the gold standard, which is the master trainer in this context, and to make sure that the measurer's measurement was close or as exact as possible to the master trainer. And here we were allowing up to 9.5 millimeters. Since this time, these cutoffs were taken from the WHO 2006 Multicenter Growth Reference Study. But since that time, they've actually reduced these down to between 4 and 5 millimeters. But you'll see across the board that in all states, all anthropometrists in all states achieved a precision that was less than 5 millimeters. And most of them achieved an accuracy of less than 5 millimeters, or just on the limits. Then for middle upper arm circumference, we tested all of our interviewers, all of our anthropometrists, and we achieved accuracy and precision less than the cutoff levels. Only in Delhi and in Karnataka did we approach or surpass our limits. In Delhi, we were at 4 millimeters of precision, and in Karnataka, we were at 4.2 millimeters of accuracy. So it was a little bit of a rush, I think, caused us to not retrain and ensure that we had even better measures, but you can see across the board that the work that we did ensured a very high quality of accuracy and precision. Lastly, with triceps synfold thickness, here these instruments are so sensitive that you have to achieve a precision of less than 1 millimeter and an accuracy of less than 2 millimeters. And we did this across the board, except in Sikkim. You can see that we passed over the limit, but we were just at 1 millimeter of imprecision. So it's still quite good, despite the fact that we surpassed that cutoff limit. So I'd like to say from these exercises that we not only demonstrated that it is feasible to do these standardization tests in national surveys, but it's necessary. It's critical to do these tests, because otherwise you have no knowledge of the quality of the work that those anthropometrists will do when they go out to the field. And so how do we know that this had an effect on our survey data quality? Well, we've gone into the effect of random error on the standard distribution of survey data. And we know that the random error increases the standard deviation of the measure. Now here we're looking at the standard deviation of weight for height. And the reason why we're looking at weight for height is because the anthropometrists were responsible to measure the weight and height, but they weren't responsible for measuring the age. So we can't hold them account for the age. So we have to use a measure that is only based on anthropometry. In that case, this is weight for height, Z-score, and distribution. So we define good data quality from a state or from produced by an anthropometrist as having a standard deviation of between 0.8 and 1.2. This means having a tight standard deviation and what is expected for our surveys. And this reference comes from a WHO document in 1995. So we did a test of all of our anthropometrists who achieved a technical error measurement less than 5 millimeters for height compared to the trainer. And we compared that to the standard deviation of weight for height that they achieved during the survey data collection. Now we controlled for a lot of other factors that we would thought might have an effect, and that we would need to control for that to make sure that we were finding a true association, a true relationship here. And what we found is that those anthropometrists that achieved a technical error measurement less than 5 millimeters, they had a odds ratio of 0.4 of having good data quality. So that those that were under that level of technical error measurement had a much higher chance of having good data quality, where those with a technical error measurement above that, then they delivered more poor data quality during the data collection. So this is a positive finding that demonstrates the effect of our standardization process on the data quality that was collected in the field. So our conclusions and recommendations are, from the CNNS survey methods and the standardization procedures, they're not just feasible, but they're essential to ensure anthropometric data quality, and that the training and the testing of survey supervision reduces the bias and imprecision in our measures, and the standardization has a demonstrable and measurable effect on anthropometric data quality. And so the recommendations that we have from our experience is that all surveys collecting anthropometry must train and test and present the test results on standardization as standard practice, and that all surveys collecting anthropometry should identify flag data in real time and request a remeasure. All surveys collecting anthropometry should also randomly request a remeasure for the calculation of the technical error measurement based on field data, and a full analysis of the data quality measures should be presented in annex of the survey report, and that can be seen in the CNNS final report. Now, what we're very excited about now is how we're using these findings from the CNNS to help improve future survey data quality. And we're working with the premier institute, the International Institute of Population Scientists in Mumbai, to develop an adaptation of the SMART methods and the standardization procedures used for use in all national and subnational surveys, not just in India, but globally. So we're developing a CS Pro tool, which are used in the National Family Health Surveys and also in innumerable surveys around the world to facilitate the process of implementing the standardization procedure. In the past, when you do this collected on paper, it's very slow. The people have the opportunity to possibly cheat. Then you have a long period of time when you have to enter the data, you have to make the calculations, you have to produce the results, you have to present those results back. I've done it several times myself in trainings of national surveys where you're working against the clock, and all of these processes can and must be automated. So with IIPS, we're working on the automation of this standardization process, where we have digital data collection, we have safeguards against manipulation of the data entry during the testing process, and we have the immediate automated analysis of the standardization test results. So this will facilitate the process enormously and make it quite easy for anyone to adapt these standardization processes into their training. And just want to show you on the right-hand side here a way we will present our summary of the technical error measurement scores. So here we're looking at height, and we're looking at, we have the gold master trainer at the first person, and then we have all of our measures following. And here we have an assessment of their accuracy and precision, and not just the accuracy and precision compared to the gold standard trainer, but also to the mean of the entire group. So this will allow us to have a little bit better measure. And then lastly, we can see the number of exact matches between the first measure and the second measure, and to determine quickly if there's been any appropriate behavior in the data collection. So on that point, I'd like to say that it's been a huge pleasure being involved in this survey, and you can see the measurements of the Comprehensive National Nutrition Survey being done on the right, and that we know that better measurements will help everyone grow to their full potential, and that's what we want. We want these children to be growing to their full stature and their full mental potential, so that we can have the best possible outcomes for not just the children, their community, but for all of India. Thank you very much. And I'm giving you back my screen.
Oh, thank you. Thank you, Robert, for that very informative presentation. And I love the notes that you ended on, that, you know, all children do deserve to grow to their full potential, and this can help us. What we can measure, we can manage. And, you know, if we measure this well, then, you know, a lot of times in the field, you know, there are two extremes, you know. On the one end, say, oh, it's anthropometry, it's just measuring heights and weights of women and children. How hard can that be? And then you see that amount of training and, you know, the kind of hands-on practice that's really needed to really get the high quality data on anthropometry. And so I think there has to be some meeting in the middle of the road of just how standardized the techniques for collecting anthropometry need to be. And so this is really enlightening, very helpful, also very excited for the project with IIPS. With that, I would turn it over to Professor Pandey to respond to Robert's presentation, maybe ask him a question or two, and then we can open it up for audience questions.
Okay. Good afternoon, good morning. Nidhi, thank you. And Robert, I would like to thank you for discussing the analysis of the effect of training and standardization on data quality with India's Comprehensive National Nutrition Survey. By taking that as an example, that measured the nutritional status of children and adolescents under age 20, that covered for the first time 5 to 14. None of the surveys have covered this age group. So that way, this is the complement. Of course, what you said, that CNNS is the largest survey covering this, you know, micronutrient deficiency among this subgroup of the population, but this is the data which is additionally available for this age group. Robert described the biases and their elimination by providing what he emphasized, the training and testing of investigators to ensure high accuracy and precision in data collection. He also emphasized standardization of anthropometry team by selecting them based on demonstrated capacity measured by technical error of measurement is required. Data quality assurance team importance also, he talked that, you know, even after identifying the good investigator, train them, standardize them, when the whole survey is rolled out and people are going in the field, then maintain that the data collection process in the field. That also he mentioned about that, this survey has a very good data quality assurance team, which has several layers of checking, and with the support of the larger team of technical resource group, which they call TRG at the Ministry of Health and Family Welfare. He presented the effect of standardization on survey data quality using TEM, and demonstrated that how that TEM less than 5 has greater propensity of giving the good data. And also at the end, in the summary, he said that he has planned to align with DHS. Why I'm saying DHS? Because National Family Health Survey in other countries is known as Demographic Health Survey. So this UNICEF has aligned with them, and also trying to adopt the smart methods of standardization procedure for use in all national and subnational surveys. For example, development and use of CS Pro, which he has mentioned, a tool which will facilitate standardization of the procedure along with the guideline, digital data collection, safeguard against manipulation during the testing, and automated analysis of standardization of the test results. I think he has covered in a very nice manner the importance of this standardization procedure, and also with example shown that how this makes the difference on the quality of data. So not much questions are there because he has very nicely covered. Only thing I would like to say that he could elaborate, maybe when other people are asking question, when it is rolled out in the field, when monitoring is being done, how these things were maintained, because the people who had less TEM, less than 5, how they have been continuously performing with the support of this or overseeing the monitoring team in the field, and what kind of input was required so that that lesson can be given to the other surveys. So I'm not going to elaborate because others may be having some questions in mind, so when their turn come, they can take their name and ask those questions. So I stop here, and I again compliment this large survey which has been coordinated by Population Council on the stewardship of Ministry of Health and Family Welfare, where it has a very strong technical research group, which was headed by the Joint Secretary at the Ministry of Health and Family Welfare, and I was also there as a co-chair with Dr. Khera, and other experts, well-known experts of the country, were there to oversee each and every step of this process, and also guide them what kind of analysis, what kind of new messages which can be brought and also could be given to the program for its immediate use, with high quality data for the program, and also giving feedback to the other surveys who can take it and also use to maintain high quality data and maintain it. And I again congratulate this National Data Quality Forum, which has thought to bring this important survey as one of the webinar, which is going to be utilized by other people. Thank you. Over you, Nidhi.
Robert, you want to quickly respond?
Yes, please.
Yeah.
No, thank you, Dr. Pandey. That is a very nice overview of all of this work. You asked a question on what happens after we go to the field with our anthropometrists, and what type of data quality assurance measures we took to ensure the maintenance of data quality over the about 4 months of data collection in every state. So we tried to reach our limits, our required cutoffs for the technical area of measurement for accuracy and precision for all of our anthropometrists. And you can see on the state level, we did very, very well. But now there were some exigencies of data collection where we did have to go to the field with some of our anthropometrists who were at the limits of the cutoffs. And so then these people, these people were kept an eye on with the data quality assurance teams. And the data quality assurance teams were there to make sure that the implementation procedures were done correctly. And so there were teams that followed the sampling, there were teams that followed the bio, and there were also teams that followed the anthropometry data collection. And so they would go and provide oversight on the actual data collection, and then within each cluster, they would collect remeasures on children and be able to compare those to the anthropometrists and their data collection to ensure that we were doing a good job while we were collecting data in the field. Now, one thing in this survey that was done was the request that to ask the anthropometrists to collect double measures of each anthropometric measure. So that means they measured the weight twice, they measured the height twice. Now, this is one part of the methodology that I find interesting, and it brings up some research questions. Is this the correct way to ensure data quality? And I think I would like to stimulate some students to do some research on this, because I think it's probably not the best way to ensure data quality. But I think the data quality is maintained by doing the solid training, doing the standardization tests, and then following up with monitoring in the field. Over to you.
All right. Thank you, Robert, for that response. We'll now take a couple questions. There are some in the chat box, but if somebody wants to raise their hands and ask questions, please raise your hands. In the meantime, I can ask one that we received in the chat box. So Rashmi Awula, she asks, she congratulates you on an excellent presentation, and then she asks, it'll be helpful to hear your thoughts on how standardization can be brought into training of frontline workers who routinely measure weight and height of children as part of the growth monitoring and make referrals based on these measures. So for a routine health information collection system, how would the survey thing translate?
Yes, no, excellent question. This is, we often steal some of our best anthropometrists from these groups of public health nurses, frontline workers who are doing anthropometric measurements on a daily basis. Now, so we do find that that there are people within these professions that have very, very strong skills for measuring children and put children at ease while they're making these measures. But not everyone in this profession and these groups do have the skills and do have even the right tools to make quality measures. So how can we bring better training to frontline workers to ensure that we do have good measurements that are coming through our health management information systems, our ICBS CAS systems? And I think that this is a process that we have to institutionalize. And I would like to see a group of trainers that go around, just like we had in the data quality assurance teams in the survey, but to also go around to all of the Anganwadi centers and the ASHAs and the ANMs that are taking measurements, and that follow up on their work and make sure that they have the correct tools, make sure that they have the correct methods, and that they know how to put a child to ease when they're making a measurement. Because a lot of these people, I think that they have the desire to deliver very solidly on their responsibilities, but they don't always have the tools and they don't always have the skills. So I would like to see these elite groups, and there's some discussion during this period of the COVID pandemic, is how are we going to start to get data to start to flow again? And so this might be a way to start to push these groups into going out to collect data once it is feasible and safe to go out and collect data, but to go out and collect data, collect quality data, and also train the frontline workers to collect quality data. Over.
Great. Thank you, Robert. And I know that we are coming up on time, but I would beg everybody's indulgence for another 10 minutes so we can take a few questions via mic as well. So the first three that we have here, Vishnu, Praveen, and Arpana. So if you can unmute Vishnu, please, and then you can ask his question.
Yeah, good evening and good morning, Dr. Johnson. It is excellent presentation. I love that first slide about the truck. Though I am working 25 years in this field, I am afraid to take the key, but I am asking the question. I will come to the history of this right from the 85 onwards, when the NCHS standards evolved for assessing the nutrition status, to the WHO states, to now the present CNNS survey. How much it changed? Are you able to see how much change of the precision in terms of the equipment, in terms of the inter and intra observable variability, in terms of the precision of the estimates and the outcome, how much it has changed? The whatever it is, if they are accurate, the policy decisions will be accurate in terms of the prevalence of nutrition status and all. How much do you think over this 30 years, how much it has got evolved towards the precision of the, especially the anthropometric estimations? Thank you very much.
So if Praveen can be unmuted.
Hi, good evening and good morning, everyone. I was listening Dr. Pandey also, and he was asking what kind of challenges were there to ensure this whole exercise of DM and getting the field going. So, being a team member, I would definitely like to add here that it was not very easy task. Getting the right team at right time and finish the survey on time was a challenge. And of course, what we did, sir, like we sometimes trained 15 people, but got like very few with a better accuracy and some with a lower accuracy. So we made two kind of team within the measurer, like one where measurer who were doing the actual measurement, and the people and the participants who were having with less accuracy or with borderline case, they were made assistant. So with mixing measurer as well as assistant, we try to manage the team. And while the Robert has also presented one odds ratio measure, that's very exciting, like sometimes odds was almost 0.4 or 2.5. So that is where it was done. But it was a great challenge, but it can be implemented with little more focus on in the beginning itself, like in planning itself, like we have to do it. Thank you.
Can you unmute Arpana and then Robert can respond? Okay, looks like Arpana is not there. Rajiv, can you unmute Rajiv, please? Yeah, thanks so much.
Thanks, Robert. It was really a pleasure to work with you on this CNNS and learned a lot on anthropometry and many other new things from you. Like you introduced the SMS system in our biological data collection to maintain the quality and the cold chain. Can you say a little bit about how we can use technology to improve upon anthropometry measure? Probably that's the future. Thank you.
Great, Robert. Can you respond to all the three questions and then we can take more if you're willing to go on for another 4 minutes? Yeah.
Yes, please. Okay, so the first question, a very important question about how data quality has changed over time. And I don't think that that this story has been well written yet, but we do know that the quality of the survey instruments, such as the height boards, has improved dramatically over time, and the scales have improved dramatically. we have the old Salter scales, where the hanging scales, where children were required to put on the pants and then be swinging around back and forth until you could try to make a measure. And we know that in the hands of that scale, only in the hands of the most highest skilled person can make an accurate measure. The same for the sort of homemade height boards, and sometimes homemade height boards that had 2 tapes on them instead of 1, and where the pieces didn't fit together properly and the tapes were stretched. So we know that the quality of our survey instruments has improved dramatically. And so now when we order our digital scales and our Shore height boards, we're very confident that we're going to be able to measure with a very high precision with those tools. But in terms, you can see in terms of the standard deviations that you find in surveys of, for example, the height for age Z-score and the weight for height Z-score, you can see it improving over time. And you can see that it's gotten a lot better. I showed you a survey from Mali that had a particularly bad standard deviation. And that survey was from almost 20 years ago. So you do see that the standard deviations are improving, but there's still space for them to improve. So if you look carefully at a survey such as the national nutrition surveys that are done in the United States, you'll often see a standard deviation of 1. And this is across all populations of Black, white, Asian, Hispanic populations. So some people do say that there's a lot of variation between these populations, but the United States is one of the most varied population in terms of ethnic background in the world, and we find standard deviation of 1 across the board. So I think there's room for improvement in a lot of surveys, and that is room for improvement in the age estimation and the measurements of heights, weights, middle upper arm circumference, and whatever other measures you'd like to make. Now, this goes straight into Rajib's point about the future of data collection around anthropometry. And I think this is so exciting. I was on a call today with a team from Weltonga Hilfa that are working on a tool called Child Growth Monitor. And this tool uses an Android phone with 2 cameras to make a 3D measurement of the child, and then from that 3D measurement to assess the height, the head circumference, the middle upper arm circumference, and they're even optimistic that they can make an estimate of the weight from the volume of the body mass. So I haven't seen the accurate measurements of weight yet, but I know it's been done in pigs, it's been done in animals, so there's opportunity to do it in humans. And I think that when this breaks through, we will have a great improvement of our data quality, and we'll also have a facilitation of being able to measure a huge number of children with a much easier facility and a greater pace than ever. And so then our science behind the measurement of children will improve dramatically. So, but even so, these standardization techniques and methods will have to be put to use before we send data collectors to the field with these new tools for making anthropometric measures. Lastly, Praveen noted some of our points on data quality assurance, and yes, through the exigencies of training, you often end up in a rush to go to the field and start data collection, but we just want to emphasize again how important this rigorous training and standardization processes are to ensure high data quality for anthropometry. Thank you.
Great. Thank you, Robert. So we just have about time for another couple of questions. We'll make these the very last questions, and then we'll close. So if you can unmute Kajuri, and we can try Arpana also another time.
Hello, Robert. This was a really insightful and interesting webinar. So I was wondering, like, what were the field factors that you faced while measuring recumbent length or say grip strength of relatively younger children? And how can these be addressed in large scale surveys with a huge sample size?
Okay, can you unmute Arpana? Is that working? Doesn't look like it is. Okay, so Sheetal also had a question. Can you unmute Sheetal? Go down and unmute Sheetal so that she can ask her question, then Robert can respond to both together. In the meantime, while we are working through it, Soumya from our team here at Pop Council has asked, do you think that in crisis or emergency situations like COVID, machine learning techniques can be used to capture height and weight? I know that you alluded to the child growth monitor and the whole Android system that's being built around anthropometry, but if you could also reflect a little bit on the machine learning techniques, as it were. So those two for now. I don't think we can get Arpana or Sheetal.
Okay, I'll go ahead.
Yeah.
So yes, the first question was on actually when you're in the field and you're monitoring the measurements of heights, weights, and hand grip strength. Now, for hand grip strength, we only measured this in children from 5 to 19 years of age. So we didn't catch that for the youngest children. The tool is basically it was almost an adult-sized tool, so it's not appropriate for measuring on smaller children. And it was largely looking more towards the risk factors for non-communicable diseases instead of the lower end of the scale, looking at acute malnutrition. So it takes a special training to make sure that you can measure hand grip strength correctly. But we did a very rigorous training and the standardization process, and it was very exciting to see the way that it was done in the field. So it can be done. Now, in terms of recumbent length, you're measuring children up to 2 years of age when they're laying down. And so this it just takes a little bit of extra training and a skilled anthropometrist. But a skilled anthropometrist can do these measures very quickly and easily. We like to put down a little towel sometimes below the child. The child is often almost naked because you're just measured the weight, and if it's hot and the child's sweaty, you don't want the child's skin to stick to the measuring board. So you lay something down like a towel, and you can easily glide that child down on the board. You can position the child very easily and quickly into position. And so one person is holding the head to make sure that the head is protected. The other one is putting the feet into place and pulling the cursor, the board, up to the end of the measurement to make sure that they make the right measure. So it just takes the process of building the skills into your hands to make good quality measures. Now, children at a certain age, between 15 and 24 months, they start to get a little testy, and they're more difficult to measure. But a good anthropometrist can put a child to ease very quickly and make an accurate measurement on the first time, and then you don't end up with a crying child. But we've all been there with crying children, desperately trying to make a second or third measure. It just takes more skill and more practice, right? And lastly, the question on machine learning for anthropometry. And I think there was a fantastic webinar not so long ago that was looking at using these types of tools for predicting food security crises, for predicting anthropometric issues. I think we have a long way to go with these tools before they can be actual real use to us for predicting the future. We need a lot of data to inform machine learning models. And so we would need longitudinal data over a long period, and longitudinal data of very high quality to be able to say that this is the patterns that we see, and these are the predictors, and so then we can guess that this situation is going to be worse than other periods or other situations. I think that there's definitely some use for it in the food security questions, but for anthropometry, I don't see the strong value into it until we get a big data source to really build upon.
Right. Thanks so much, Robert. I think you kind of hit the nail on the head. Machine learning has like no native intelligence. The patterns that the data presents, it predicts based on that. So if you have very high quality, a large volume of very high quality data, then only can it be deployed in any attainable manner. So that's great. And then with that, I would like to thank everyone, thank Robert, thank Professor Pandey for this great discussion. And I would like to thank our audience for their active engagement. I know that there are many, many questions in the chat box that we couldn't get through. And we will try to find some way to address these in the coming weeks. Thank you very much, and have a good evening and the rest of your weekend. Bye-bye.
Thank you, everyone.
Bye.
Thank you, Robert. Very good. You have answered, but I would suggest that the answers which you have given that need to be documented. For example, the coping mechanisms which were adopted in the field, those things need to be documented. It is good that Praveen reminded at that point how we are dealing in the field. Those things are not known, and so future surveys may like to take advantage of those experiences. And similarly, as you replied to Dr. Vishnu Rao's questions, how improvement has taken place, and you also mentioned that there is no story available. So if it is not available, you answered, so some story may be prepared and may be put in place so that people can use. And also you can emphasize using this smart even by the frontline worker, and your proposal that expert group of the anthropometric measurement may be formed, and who can go around the country and provide good capacity building to the people who are working in the field. So with this, I again acknowledge my gratitude to you and whole team who has been working with CNNS so hard, Population Council, the UNICEF, and other institutions who are involved. Really, that is praiseworthy. So my compliment to them. Thank you.
Thank you so much. Thanks, Professor Pandey. Thanks, everyone. Bye-bye.
No, thanks. At the end, thanks, Nidhi. So nice coordinating this, and Radhika. They have done a wonderful job, and so nicely they have compared and brought the things at the front. Thank you.
Thanks for your kind words, Dr. Pandey. Thank you so much. Appreciate it. Thanks. Bye-bye.
Thank you.